Hi, everybody. I'm Dr. Carolyn Alexander at Southern California Reproductive Center. I'm so excited to be here with one of my dearest and longtime friends, Debrin Cohen. Thank you so much for joining us today. How's your day going? I miss seeing you.
I am too. I miss seeing you. Everything's going well, thankfully. I'm so happy to be here.
Awesome. And Leia's helping me with the slides. So I'll tell you a little bit about me. I was born in LA. My research and passion has been egg freezing and patients for polycystic ovary syndrome, doing research to understand what's the cause, what can we do to help all the patients. And I've done research on recurrent pregnancy loss as well as patients who are faced with cancer and want to talk about fertility preservation options. I went to UCLA for medical school and college, and then I worked at Johns Hopkins Hospital for residency and fellowship. And then I was an attending at Cedars-Sinai, associate residency program director for many years. And then now I've been part of SCRC for over 10 years, and it's been a joy to be a part of it here. And Debrin, can you tell us a little bit about yourself too?
Absolutely. Another born and raised in LA girl. I've been a dietitian for 8 years now, and the bulk of my career was also at Cedars-Sinai, where I learned a lot. Dr. Alexander is actually one of the reasons why I went into private practice, and based off of my own experiences with PCOS and fertility and just being a woman, and now a busy mom, I've just had a passion to help other women. And that's what I mostly do in my private practice.
So great. I know you've helped me, so thank you for mindfulness and eating. So at SCRC, I work closely with a group of doctors here, and we've been part of our embryology lab, which is called ART, has been there for 25 years. We have a facility also in Santa Barbara, and our Pasadena has a clinic office. In Santa Barbara, they have a full embryology team as well. And all of us give compassionate care and work really hard to get the best success for every patient. Next slide. What sets our lab apart? We have experienced embryologists, a double witnessing verification. So two people look at the name and date of birth and are very cautious. We do vitrification for egg freezing as well as blastocyst freezing, which is called flash freezing, which has the highest success of survival of the thaw. We do PGTA-NM, which is pre-implantation genetic testing for aneuploidy screening and for monogenic disorders. And so we look at all the chromosomes as well as gender if patients want to know that. We talk about the embryoscope, which is time-lapse morphokinetics, which gives us many data points over how the embryo is looking. We also have certified directors and work with our teams to make sure everything's as up to speed and advanced as we can possibly do. Next slide. We're going to talk a bit about PCOS Awareness Month, diet for PCOS and fertility optimization. How do we evaluate a couple that's facing infertility or a patient who's thinking about fertility preservation, which can be eggs or embryos? We'll go over our teams and any special offers, and we're happy to answer any questions as well. Next slide. September's PCOS Awareness Month. Next slide. Go ahead, Debrin. I'm so excited.
Well, again, thank you, Dr. Alexander, for having me here today. As I mentioned, this topic is personal for me because I also have PCOS and I've struggled with its fertility challenges. But thanks to Dr. Alexander's support, I was able to overcome those challenges and have my beautiful children. So I'm really excited to be here and share how nutrition and lifestyle can help women with PCOS. Let's get started. Unfortunately, PCOS affects about 1 in 10 women, making it the most common hormonal disorder in women of reproductive age. It's a leading cause of irregular periods and ovulation, resulting in infertility. PCOS is marked by hormonal imbalances, including higher levels of androgens or male hormones, and insulin resistance, which means the body has trouble using insulin properly, which then impacts blood sugar control. Next slide. To diagnose PCOS, doctors typically look for 2 of 3 main signs. First are the elevated androgens, which can show up on labs and physically appear as acne, hirsutism or excess facial and body hair, or male pattern baldness. And second is irregular or absent periods, which indicates issues with ovulation. Finally, the most known, polycystic ovaries, which can be seen on an ultrasound as enlarged ovaries with many small immature follicles. It is important to know that not everyone shows all of these symptoms, but diagnosis is typically 2 out of the 3 criteria. Next slide, please. So let's talk a little bit more about the hormonal imbalances in PCOS. First one is hyperandrogenism or elevated male hormones. This causes the symptoms I just mentioned, like the acne, unwanted hair growth, thinning hair, and irregular periods. Then there's the insulin resistant component. This is when the body doesn't respond well to insulin, which leads to higher levels, raised blood sugar, and then that also worsens the symptoms of the excess androgens. Lastly, low levels of progesterone can disrupt the menstrual cycle, making it harder for women to get pregnant. Next, please. Some other symptoms, women with PCOS often experience weight gain, and that's especially around the abdomen. That's largely because of the higher androgens and the insulin resistance. Those are the 2 that keep causing the problems. The high insulin levels cause the body to store more fat, making it harder to even lose weight. This also increases the risk of high blood pressure, cholesterol, and then heart disease. Another common symptom is fatigue because of the poorly regulated blood sugar, and some sleep issues like sleep apnea or insomnia, which then just adds to the fatigue. The hormonal imbalances can also affect our mood, causing mood swings, depression, and anxiety. Next slide, please. So there are a lot of downsides to PCOS, but there is some good news. Diet can play a huge role in managing those symptoms. One of the most effective ways to manage PCOS with diet is to focus on foods that are low on the glycemic index. These foods cause a slower rise in blood sugar, which then improves that insulin sensitivity and helps balance our hormones. Some examples of low GI foods are whole grains like brown rice and quinoa, legumes like lentils and chickpeas, non-starchy vegetables like spinach and broccoli, and fruits like apples and berries. It's also really helpful to include anti-inflammatory foods since chronic inflammation is also often seen in PCOS. Some great options include leafy greens, berries that are rich in antioxidants, and fatty fish like salmon that are also high in omega-3 fatty acids. Using the plate method is the simplest way to balance meals. You fill half your plate with fiber-rich, non-starchy vegetables, a quarter of your plate with lean protein, and then the last quarter of your plate with whole grains or legumes. This nice balance helps keep your blood sugar stable and make sure you're getting a variety of nutrients for overall health. I want to emphasize protein, especially with every meal or snack, because it stabilizes blood sugar, reduces cravings, and helps keep us full. Some great sources are lean meats, fish, legumes, eggs, and tofu. Okay, supplements. These are some supplements that can provide additional support in addition to the diet and lifestyle factors that can help PCOS. Myo-inositol is one of the most recommended for PCOS because it supports ovarian function and improves insulin sensitivity, helping women with PCOS manage their periods and weight. Omega-3 fatty acids, as we mentioned with food, is also great for reducing inflammation, improving insulin sensitivity, and enhancing the quality of eggs collected during fertility treatments. Berberine helps regulate insulin too. And acetylcysteine also supports ovulation, improves insulin sensitivity, and reduces oxidative stress. Magnesium is one of my favorites. It's an important one overall because it helps regulate insulin and reduce inflammation, which can then ease the symptoms like high blood sugar and insulin resistance. It also can help support heart health, promote better sleep, help manage stress and anxiety, and relieve some GI stuff like constipation. Prenatal vitamins or a multivitamin with high quality folate and B12 have been linked to better fertility outcomes. And CoQ10 is a great supplement for women who are going through fertility treatments since it's been shown to improve egg quality and increase the number of high quality embryos. Last but definitely not least, vitamin D plays an important role in supporting insulin sensitivity, ovulation, menstrual regularity, and fertility. So as I mentioned, these supplements with diet and lifestyle can help women better manage their symptoms, improve their overall health and their fertility. Next slide, please. All right, we've talked all about women with PCOS, but it's important to note that fertility is a shared journey. Men's reproductive health is equally important. And with that in mind, there are some supplements out there that can help improve their fertility outcomes. Proceed is a clinically proven supplement that enhances sperm quality, count, concentration, and motility, thanks to ingredients like L-carnitine, acetyl L-carnitine, and folic acid. CoQ10, again, is key for male fertility as well. It's shown to significantly improve sperm concentration, density, and motility. And vitamin D, again, can also help improve sperm count and quality, which are both essential for conception. Next, please. All right, lifestyle choices. These can have a big impact on PCOS and fertility. Alcohol, for example, can increase insulin resistance. That then messes with hormone regulation and ovulation. Research shows that having more than 4 drinks per week during IVF can lower live birth rates and increase risk of failed fertilization. Cannabis use has also been linked to fewer eggs retrieved during IVF, as well as a lower percentage of eggs being fertilized. Smoking worsens inflammation and oxidative stress, insulin resistance, and androgen levels, all leading to more severe symptoms with PCOS. Additionally, smoking can lower egg supply, increase the risk of pregnancy loss, and decrease the chances of a live birth. Again, food, especially processed food and foods high in omega-6 rich fats, should be limited as much as possible, as they can worsen inflammation and make it harder to regulate our hormones. So by either limiting or avoiding these certain lifestyle factors, couples can improve their chances of successful conception and have healthier pregnancy outcomes. Next slide, please. All right. One of my favorite quotes, knowledge isn't power until it's applied. To truly make progress, having the right mindset and using practical strategies are what make the difference in the long run. Managing PCOS and infertility can bring emotional and physical challenges that feel so overwhelming. Focus on making small, gradual changes. Start by incorporating whole foods, rich in fiber and protein, like vegetables, legumes, lean meats, and whole grains. Plan ahead and meal prep. This will help you make better choices and stay on track, avoiding any last minute, less nutritious decisions. Also, setting aside each week to plan your meals helps with having a balanced diet overall. It also takes the guesswork out. Most importantly, practice self-compassion. Be patient and kind to yourself. Studies do show that self-compassion improves resilience, creates room for growth, which makes it easier to stay consistent and motivated even when things get rough. So with a combination of practical diet and lifestyle recommendations mixed with self-compassion and patience, you can create a strong foundation for long-term success managing your PCOS and improving your fertility outcomes.
Thank you so much, Deborah. And I feel calmer hearing you. And you reminded me to meal prep. When I do, I feel like it helps me a lot too, that I'm less, stressed of what will I have as a snack. And the team tends to have a lot of unhealthy snacks, but I pretend they're not there. But thank you. That helps us a lot. And I know I've struggled a lot with the hirsutism and the higher, the abnormal hair growth and sometimes hair loss. So I always feel for patients who come in, and I feel like I completely understand it's really hard, but I've learned tricks from you and from just reading so many articles to help us get, and now I'm over almost to 50. So it's kind of like now I feel like I want to write an article about perimenopause and PCOS to understand it better, because I think it's kind of a neglected topic, for patients as well. But next slide. So as the ovaries age, just as time goes by, we were having the most eggs in our ovaries when we were in pregnancy, in our mom's abdomen, when we were a 7-month pregnancy, when she was pregnant. And then as time goes by, when we got to puberty, we have around 400,000 oocytes or potential eggs that are in the ovaries. The ovaries have a cortex, which is the outer rim, and that's where the eggs are. And once we start to get into our fertile window, there are around 400 to 500 oocytes that are available. And as time goes by, the definition of the M word, menopause, is 1 year of no period. And so that tends to start on average when we get into our 50s. Next slide. It's important to understand your medical history, make sure your pap smear is up to date. If you have any thyroid imbalance, to optimize the endocrine system. If you're skipping your periods, it can also be due to high prolactin, which is associated with polycystic ovary syndrome. So it's important to check a fasting prolactin level. It's also very important to understand that if you've had prior surgeries such as cyst removals or endometriosis, if you've had an endometrioma, that can also impact your ovarian reserve. And in addition, it's important to understand that keeping a healthy lifestyle with diet and exercise can improve your overall health as well as blood flow to the uterus, so that when you're trying to get pregnant, it's not just egg quality, but also the health of the uterine environment. When we are skipping our periods, sometimes the building blocks in the lining of the uterus, called the endometrium, can get thick, and that can have a risk factor for hyperplasia. And so some of the patients, when they come in and say, oh, I haven't had a period in 6 months, when we do an ultrasound, we like to make sure, if the lining is super thick, to have a discussion with the patient and maybe their OBGYN about a possible endometrial biopsy to check the uterine lining. We also like to make sure, if they have insulin resistance, that pre-pregnancy elevation of the hemoglobin A1C can have an impact on the development of the embryo, which can impact spina bifida, which is a congenital anomaly, as well as other anomalies. So when we are preparing people to get pregnant. We want to get the vitamin D level optimized, avoid iron deficiency, make sure your B12 level is healthy, make sure you're as fit as possible, and that the uterine environment is as healthy as possible to conceive naturally or, if needed, with fertility treatment options. When we do the physical exam, we like to make sure the cervix looks healthy. The other day, I saw a patient where on the cervix there was a little area that looked inflamed, and I had her check with the OBGYN, and it was actually real precancer. So it's important, since the recommendations started to stretch out to every 3 years, I always think before pregnancy, it's like preparing for the Olympics. We want to be up to date with our pap smear, our annual physical exam, make sure everything is as on target as we can be before we get pregnant. And then one of the testing is called ovarian reserve testing. And people always get really stressed when they're doing some of the home kits, which are helpful for some cases, but sometimes with some of the saliva kits or home peripheral blood kits, they may or may not give an exact accurate value. But AMH is called anti-Müllerian hormone. It's produced by the granulosa cells around the rim of the follicle. And those cells, when we're aged 26 to 29, should produce an AMH 1.96 to 5.88. When we're 30 to 35, the level starts to little bit shift downward, so it can be 1.4 to 4.2. 36 to 39, 0.84 to 2.8, but we generally would want it above 1. And 40 to 44, it tends to be 0.42 to 1.4. But again, we're hoping for it to be at 1 or above. And when we get over 44, it can be in the range of 0.14 to 0.42. And if it's lower than that, we start to have a discussion about the egg supply is starting to really shift downward. On the right is an ultrasound where we count the antral follicles. Each little black circle has a microscopic egg the size of a grain of salt, and that has a potential to be genetically healthy or not. I think we have a slide about that. Next slide. In back to the genetics, when men are over 50, we do see an uptick in autosomal dominant disorders as well as epigenetic disorders. As women, when we get to age 35 and when we're above 40, there's a higher risk of aneuploidy or chromosomal abnormalities in the eggs. And that's why we always are hoping and praying for the golden egg or the genetically best egg that wants to be fertilized with the best looking sperm. And so a semen analysis, we should have the men ejaculate 2 to 5 days before their appointment. The volume should be over 2 milliliters. The concentration over 20 million per milliliter. The motility over 50%. And the morphology, which is the image on the right, should be normal with the head, the mid-piece, and the tail. And sometimes if we are exposed to plastic pollution, artificial sweeteners, heat, such as sauna, jacuzzi, long bike rides, we might see more of the abnormal shaped sperm. Studies indicate that 25% of infertility is primarily from male factor, but 40 to 60% of infertile couples, it's a combination. So it can be both the egg issue and the sperm issue. So it's important to optimize sperm parameters. Since COVID hit, we do notice that sometimes after having COVID, sperm DNA fragmentation is higher for a while. In addition, if someone's had a fever, 72 days later, that sperm sample could be impacted and slower. The motility could be impacted from a high fever. So it can, in men, there's a turnover of around 72 days. Next slide. The hysterosalpingogram, or HSG, is an evaluation of the fallopian tubes where the egg and sperm meet in natural fertilization. And so it's an X-ray done to evaluate the fallopian tubes and the uterus. There are some tests that can use bubbles instead of an X-ray, as well as in some cases, if you've had the fallopian tube test, we don't necessarily need to repeat it. It is very uncomfortable, so I recommend Motrin, 600 milligrams, 30 minutes ahead of time. I usually talk to patients about prophylactic antibiotics to protect from an infection that could happen from this procedure. In addition, some patients do need a Valium to have the muscles relax because sometimes getting the catheter in can be challenging in some cases. And so it's important to talk to your doctor specifically about your situation. And we always are hopeful that both fallopian tubes are open. If someone's had an ectopic pregnancy, which is a pregnancy in the fallopian tube, it can impact when we do this test, that side could be closed. It also, if someone has endometriosis, it can weigh down on the fallopian tubes and prevent the end of the fallopian tube, called the ampulla, from being open. If we've had unprotected chlamydia, it can also, untreated chlamydia, it can also impede the fallopian tubes and cause them to be unhealthy. So when I give talks to college students, we talk about how to protect your fertility for the future. We always say it's important if you have a new sexual partner to have an STD check before unprotected intercourse if possible. If you've had unprotected intercourse, it's important to get a checkup, make sure there's no gonorrhea or chlamydia, HIV, hepatitis B, hepatitis C, syphilis, and if you've had any untreated abnormal discharge, get a checkup with the doctor. Next slide. The hysterosonogram is a specific test where saline is carefully placed in the uterus to evaluate the uterine cavity for polyps, scar tissue. Some people after a miscarriage can have a little retained piece of the pregnancy, as well as some patients can have a fibroid, which is a benign tumor that can push into the uterine cavity. There's different types. And so a hysterosonogram is very helpful before an embryo transfer to make sure there's no surprises when the embryo is going to be placed inside, that there isn't anything we should have fixed before the embryo transfer. Next slide. So IUI is intrauterine insemination. It's one of the fertility treatment options when patients are coming in where they want to use donor sperm, they don't have a partner right now, or they're in a same-sex relationship and want to use an anonymous or directed donor sperm, we can do IUI. If the semen analysis of a patient's partner shows low motility, but the concentration and volume are good, we could consider IUI to get the fastest swimmers up to the top of the uterus. And IUI can be done with your natural ovulation or with super ovulation with medications such as Clomid or Letrozole or FSH injections. And when the follicle gets to a certain size, we can use a medication that's been around for years called HCG trigger shot that's done when a follicle is at a specific size and the uterine lining at a thickness. And we can plan the timing for the IUI depending on when you're ovulating and place the sperm in. You're here for a little while because it takes a little time to prepare the sperm. You lay here for 15 to 20 minutes after the sperm's placed inside, and you can go on your day. You don't have to go home and lay with your legs up because once the sperm is placed inside, the egg and sperm has an opportunity to combine or fertilize in the fallopian tube. It's important if you're considering IUI to talk to your doctor about whether or not you need the HSG or the fallopian tube evaluation. And it's important with IUI to make sure that the sperm and the egg don't carry the same genetic issues such as cystic fibrosis, Tay-Sachs, Gaucher, sickle cell trait, thalassemia, there's a panel called genetic screening. And sometimes it would be better to know before you're pregnant if either could carry a similar gene. And that's called genetic carrier screening prior to pregnancy. In addition, before an IUI, it's important to make sure you're up to date with all your annual checkups. If you're near age 40 or at 40, talk to your doctor about a breast ultrasound or mammogram if needed. If you have a strong family history, it's important to get a checkup younger than that. It's also helpful to talk to your doctor about luteal phase support with progesterone after the IUI if it's necessary. Next slide. The other important thing to understand is when we place the IUI and put the sperm in, depending on the patient's age, as well as the egg quality, as well as health factors, the success of an IUI at the best can be up to 15%. And so the range can be pretty low if we're in our 40s. And even though in my mind, I'm an optimistic person and I want every IUI to be successful, the hard reality is the chances of conception with IUI after a patient's been trying for many years or is faced with infertility, it's not as high as we were hoping. But with IVF, because we're able to get the eggs out with an egg retrieval, place the sperm into the egg and make an embryo, we have a much higher opportunity to get pregnant, and we could potentially save extra embryos for future planning for another pregnancy down the road. Next slide. So with egg retrieval, I saw one of the questions was, how much time do I prepare? It does depend with your doctor and you to discuss your AMH level. Sometimes if some patients are faced with diminished ovarian reserve, we don't give them the month to 3 months to take all the vitamins, do acupuncture, talk about nutrition and lifestyle modifications because time isn't always on our side. But generally speaking, the egg quality is impacted by what we did the last 3 months. So if someone's been having heavy alcohol intake, marijuana, tobacco, really eating a lot of fried food and unhealthy food, it's important to think, okay, game on, I'm ready to face fertility treatments. I want to prepare myself. So then I talk to people about, like Debrin mentioned, nutrition, amp up the exercise if they're having a sedentary lifestyle. If they're over exercising, sometimes we have to talk about cutting down, especially running a tremendous amount per day, many days in the week. Sometimes that can impact the body's desire to ovulate. And so it's very tailored to your specific case. But we do prepare ahead of time to make sure your vitamin D level is healthy, thyroid, all the pre-testing for ovarian reserve testing. And the baseline ultrasound counts the follicle count. And then there's ovarian stimulation. There's many protocols that can be chosen, and it's dependent on your specific case and your levels and your medical history. But the ovarian stimulation can take 10 to 12 days. And then there's a trigger shot to loosen the eggs from the sidewall so that we can prepare for a 15 to 20-minute procedure called the egg retrieval, which is under anesthesia. We have an anesthesiologist here who works closely with us to monitor you while you're under for the egg retrieval. That morning, you don't have any food, vitamins, or any water, and for about 8 hours before the procedure. That night, you need a heating pad and Tylenol because it's very crampy. And for about 7 days, you can feel bloated and uncomfortable. And the most common phone call is constipation. We do try our best with the patients with polycystic ovary syndrome to avoid ovarian hyperstimulation syndrome, which can cause electrolyte shifts as well as can increase the risk of blood clotting. And with high estrogen levels, we don't like traveling for about 7 days after the egg retrieval for the risk of a deep vein thrombosis or pulmonary embolism. So it's important to talk to your doctor if you have a strong family history of those things, or if you ever took birth control pills and had a blood clot with egg freezing or IVF, we want to protect you with a blood thinner during the process and talk to your doctor about ways to protect you. Next slide. So this is a really nice picture of the transvaginal probe with the thin needle that goes through the wall of the vagina into the ovary under ultrasound guidance. And so the bottom image shows the thin white needle going into the ovary, and the each black circle has one microscopic egg. Sometimes the trigger shot doesn't allow the egg to loosen up from the sidewall. Sometimes if the patient's under a lot of stress or has a history of endometriosis or inflammation, the egg may or may not want to come out with the egg retrieval. In addition, some people think that if the genetics of that egg is not as healthy, it can't do the mechanism to loosen up from the sidewall to come out with the egg retrieval. But generally speaking, we're hoping to get one egg per follicle in the follicles that are over 15 to up to 22 millimeters. And depending on your clinic, there's different protocols and guidelines to when to decide how many days of the medication is enough to get the pool of eggs to be as mature as possible so that they can be frozen or fertilized depending on your goals. Next slide. This is a beautiful image of ICSI, intracytoplasmic sperm injection. We go 90 degrees from the polar body, and we use a thin pipelle to place the sperm that's been immobilized into the egg to allow for fertilization. There's another option too, where we dip the egg with 20,000 sperm. That's called natural insemination for the egg. But in cases where patients have struggled to get pregnant or the sperm quality is suboptimal, ICSI is a better opportunity to fertilize the egg. It does have some risks in some situations, especially when paternal age is advanced, or if the male partner is on a lot of medications, or if he has a family history of any specific genetic issues as well. So next slide. The EmbryoScope technology provides information. It won't change the genetics of the embryo, but sometimes if we're blessed with more than one genetically good embryo, it could provide data to say this embryo might be better than this embryo, because we get 1,000 data points to evaluate, and the team in the lab can look at the details to understand a little more information. Sometimes if patients come to us from other places where they didn't make any embryos, the eggs fertilized, but then there was a halt in the development, it does give us some information. As Debrin mentioned, it's not always the egg. It can be exposure of what men are doing. So again, talking a little bit more about CBD oil, vaping, marijuana, and improving sperm parameters and sperm health overall as well. Next slide. And the embryo develops from the fertilized egg to 2 cells to 4 cells to 8 cells to 16 cells up to a blastocyst over 7 days. This is an image of an embryo biopsy where we take a few cells from the future placenta, and we are able to look for chromosomes there. We also can, in some cases, if patients both carry a specific gene, such as cystic fibrosis or even Tay-Sachs or sickle cell trait or thalassemia, or sometimes we have patients who carry the early Alzheimer gene or BRCA1 or 2 and specific genes, we could help the next generation avoid those issues by doing this biopsy and evaluating the embryos. For chromosomes, it's not a perfect test, and there's been a bit of a pendulum swing with it, especially in patients who are younger. If taking those few cells is really going to reflect the inner cell mass, which is the baby to be. And so it's important to discuss all the pros and cons with everything we do with every patient, depending on the age of the paternal and maternal age, as well as any family history. Next slide. For preparation for frozen embryo transfers, it's important in that month or two ahead also to exercise, eat healthy, take your prenatal vitamins for folic acid to prevent spina bifida, make sure you're as healthy as possible. It's important to talk to your doctor about evaluating the uterus to make sure the embryo can attach as long as there's no polyps, scar tissues, fibroids in the way, or any obstacles. And it's important to think about after the embryo is placed inside. I always say we want to pretend we're pregnant and eat as healthy as possible, avoiding things that could have too much mercury or listeria, such as soft cheese. And so it's good to think about strategy when you think about the embryo transfer. And we work really hard here to get every embryo to attach and to help our patients through all the steps involved with a frozen embryo transfer. Next slide. It's good to remember that fertilization typically can occur around 70 to 80% of the time. Blastocyst development is around 45% of the time. Embryo survival is into the high 99.6%, but the egg survival has been hovering around 87 to 90%. So when people say, I'm not ready to fertilize the eggs, they may or may not have a few that don't survive the thaw. And depending on the quality of those eggs, the fertilization can be impacted as well. But an embryo to implant or stick in the uterus has been really improved over the years. In my career, that number has improved a lot. There have been approximately 6,000 babies born with no increased maternal fetal complication or aneuploidy from eggs frozen. And so that's happy information for us. Next slide. So our team here at SCRC, we've helped many couples, many people get pregnant, and we work tirelessly to think through how to get the best success for each patient. Next slide. And for attending the webinar, you get 50% off the initial consultation, as well as there's a lot of resources on our websites and on I know Debrin has a wonderful, a lot of plethora of information too. And next slide. I think we were going to go over some of the questions. I don't know if you want to start, Debrin.
Sure. I see a question that piques my interest. It's a question about fasting. So this is a question I get all the time, not just for women with PCOS, but in general nutrition, with the big hype on intermittent fasting right now. And my answer is kind of ambiguous. So the question is fasting safe if you have PCOS? Now, in general, we fast from nighttime when we last eat to breakfast when we first eat. With intermittent fasting, that window is expanded, so the window of eating is very short. And that typically ends up with like less calories consumed, which is when people end up losing weight in intermittent fasting. Now, there's some conflicting information on that, and then there's some positives of intermittent fasting showing, improved cells and specifically with like cancer and things of that sort. With PCOS specifically, I do not recommend it with my clients because there are a lot of women with PCOS who also suffer with eating disorders. And a lot of us women with PCOS have tried every fad diet there has ever been. And these fad diets, whether it's the ketogenic, paleo, intermittent fasting, you name it, they're not sustainable. And because of that, they can increase our cortisol, which is our stress hormone. just cascading all of the other hormonal imbalances, the insulin resistance, the androgens, it just makes everything worse. So rather than focusing on a specific way of eating, I like to recommend eating every 3 to 4 hours and following that plate method as best as you can, or having protein or fiber with each of your meals so that you can mitigate that blood sugar spike and keep your blood sugar balanced just to make everything else go smoothly.
That's so helpful. Yeah, I notice for me, if I avoid food after 8 p.m., it helps me a lot in terms of even just the hunger the next day. It's like it's a little better for me. But I typically tell patients, especially ones ready for an embryo transfer, I notice when patients skip breakfast, they can get ketones, and ketones can cross the placenta. So we don't really want to get ketotic when we're early having an embryo inside or early embryo development. So that's important. Um, I saw a helpful question, and I almost added a slide, but I thought it was a little too much information. But one person asked, what if they don't have eggs? And sometimes even patients in their 20s can have what's called premature ovarian insufficiency, where we're faced with a very high FSH level, which is the hormone from your pituitary gland that controls ovulation, and it goes higher and higher if our egg supply is lower and lower. And some of the patients can have an AMH that's 0.003, 0.001, where they're really not having an egg supply left. And so then we have to have a heart-to-heart with them about what's called an anonymous or a directed egg donor, where it's someone, it could be someone of your similar height, weight, ethnic background, and those eggs are fertilized with who you would like, and you carry the pregnancy, because in pregnancy, epigenetic changes can happen. And there are many stories. One of my first egg donor babies, I think he's 15 or 16 now, she brings him every single year because I really encouraged her to think about the egg donor. At the time, it was very sensitive for her. And she brings her son every year, and it's always interesting because he has certain traits that are just like her. And she had asked me to ask the egg donor, and the egg donor doesn't have those traits or in her family. So it was kind of fascinating. That was just a case where I realized epigenetic changes can happen. But in a sense, in some cases, no matter how hard we try with the medications, some patients can't recruit follicles, or potentially the egg quality or quantity is depleted. So I think that was an interesting question. Thank you for asking that. Debrin, do you see one?
I do. It's a supplement question. So, out of the 8 supplements discussed, would you advise taking all of these, and how many months prior to egg retrieval for egg freezing? So, every body is different. And for that reason, I can't say take all 8 supplements, take one of them. There's also so many other supplements. So, first and foremost, I'd advise you to meet with your primary care physician, your OBGYN, reproductive endocrinologist, and get some labs drawn. Anything from your hormone levels, fasting insulin, your hemoglobin A1C, even micronutrients like zinc and vitamin B12, iron. And then from there, you could see which one of the supplements would best be suited for you in your case. Or maybe you're taking certain medications like metformin. Metformin and inositol do very similar things in the body. So taking both may not be necessarily appropriate for someone. So per person.
Yeah. I see a egg freezing question. How many eggs do I need to have a baby? Well, it depends on your age, but we did look back at the last 5 years, and at age 37, we needed 17 to 20 eggs to get a chance for a pregnancy. And that was partly because about a third of those patients, the sperm was so. And so it wasn't always because we need so many eggs. It was because the fertilization was based on the sperm parameters and they were so-so. So again, before people thaw their eggs here, we have men go on vitamins, do lifestyle modification for 8 weeks before they thaw their eggs. So it's important to talk to your doctor about that, especially if he's on any specific medications, like some blood pressure medications, or some men are on Propecia or Rogaine, and that can impact sperm quality as well. So it's good to really tailor the situation to your case, but it does take a lot of eggs to get a chance for a pregnancy. There are always cases where people had a few eggs, they thaw them, fertilize, they make a good embryo and get a pregnancy. But generally speaking, it does seem to take over 15 eggs to get a chance for a pregnancy in general. And our average age of patients coming in is 40. And so we do have some statistics at 40 that we do need over 25 eggs to get a chance for a pregnancy, which is kind of a lot because some cases we can only get a limited number per try. So it's a very case by case discussion as well. Do you see any questions for you? I saw caffeine. Do you want to do that one?
Our eyes are on the same thing. So it's a really great question. The question, which is, first off, this is an excellent presentation. Thank you so much for this. Thank you for joining. And the question is, can you please discuss the impact caffeine has on egg freezing or preparation for fertility treatment? So to my knowledge, my experience with caffeine, fertility, and it's very similar to pregnancy. We recommend nothing more than 200 to 300 milligrams. Things excess of that, so 400 to 500 milligrams, have been seen to increase the risk of miscarriage, for instance. And Dr. Alexander, is there any relationship to fertility treatment and egg freezing with caffeine?
Sometimes if we're having too much caffeine, the blood flow to the system is a little bit interesting. But generally speaking, I try not to be too judgmental because everybody might need a little bit of coffee, but we transition to 1 to 2 cups or less if possible of caffeine. And then once you're pregnant, sometimes you actually don't feel like you would want coffee per se. So it's important to not have too much caffeine in early embryogenesis for a slight uptick risk of miscarriage. So it's good to not have an extreme amount, like 2 ventis at Starbucks and stuff like that. Yeah.
On that note, there's a lot of sugar in 2 ventis at
Oh, I
Starbucks.
know. Yeah, I always get it with none of the add-ons, but I always am attracted to the colors and stuff. But I see a question: nervous for PCOS and coming off birth control pills for fertility treatments for egg freezing. So I think it's tricky with birth control pills because we do, when the AMH is over 8, it's sometimes helpful to have the patient on birth control pills before egg freezing because their inflammation's lowered. But when the AMH is lower, it's much better to stop the pill for a month or more, especially if we've been on it for 10 years, because the ovarian function is suppressed by the pill. And so it's a case by case basis. We have had patients stop the pill and unintentionally get pregnant. So it's also, if you're using it for contraception, it's important to have backup contraception. But and then there are cases with polycystic ovary syndrome where patients stop the pill and don't get their period for a few months, but they're eager to get some eggs frozen for their future preservation. And so then they're just waiting and waiting for their period, because we always say, call us when you get your period. So it's important to have a discussion. If it's past 40 days without having a period when you're not on birth control pills, it can build the building blocks inside the uterus to an unhealthy level. So it's good to talk to your OBGYN about strategy of what to do for that situation. Any other questions? Let's see.
This one sounds interesting for you. PCOS, is it true that PCOS gets better with aging? Like when
That's
achieving
interesting. Yeah.
48 to 50 years old, it disappears?
Yeah, sometimes the anovulatory, the lack of ovulation starts to regulate a little better because testosterone can start to shift down from the ovaries. But in our, when you hear about family stories, you'll hear, oh, my great aunt had a kid and then 10 years later had a baby. It's because she suddenly started to ovulate in her 40s and had a spontaneous surprise pregnancy. And then they'll say, oh, yeah, she had diabetes or hirsutism or the hair growth and was a bit overweight. And so sometimes there's that family tree where people will say that. But I think it's because there's a little uptick in ovulation when we get older sometimes, but also it's a case by case situation. No matter what with PCOS, if our cholesterol's not under tight control or we have more inflammation markers, there can be a slightly higher risk of cardiovascular disease and type 2 diabetes. So it's important in the perimenopause to have a really detailed, good primary care doctor too. Let's see,
So great.
I think we answered a lot of them. We did the caffeine. We talked about donor egg. Any other questions today? Thank you guys for joining us. See if anything came in.
Doesn't look like
Oh,
it.
if you have
Hopefully.
no eggs and use the donor egg, can you carry the baby? You can carry, even if a patient's in menopause. We have patients come back for the frozen eggs they froze years ago. Like I have a patient now, she froze the eggs 15 years ago and she doesn't get her period. So we're gonna have to she has to make sure her pap smear mammogram, her doctor says okay and all these things, but we can get her to take medication to thicken the uterine lining so that the embryo can attach. So you can carry a pregnancy even if you have no eggs or there are some age limits, especially here. We have our ethics committee has a lot of age limits. So it depends on a case by case basis. So
Oh, you are a magician.
thank you, everybody. Thanks, Debrin.
Thank you
Let's
so
have coffee
much.
soon. It's good to see you. I miss you. Give the kids a
You
hug
as well.
for
I
me.
will. Thank you so much.
Take
Have a
care,
great night.
everybody. You too. Best wishes. Bye-bye. Thank you.